Hello, everyone. This is a case report on Shwachman-Diamond syndrome. The objective of this case report is to emphasize the importance for disease awareness due to variable phenotypes and presentations of this syndrome. What is Shwachman-Diamond syndrome? It's a rare inherited disorder mainly caused by mutations in a gene called Shwachman-Boden-Diamond syndrome gene, or SBDS gene on chromosome 7. But other genes like EFR1 gene can be involved as well. It's a multi-organ disorder, and individuals commonly present with bone marrow failure, exocrine pancreatic insufficiency, cognitive disorders, and bone malformations. In this report, we highlight a unique presentation of Shwachman-Diamond syndrome. Our patient was a 31-year-old Caucasian male who presented with chief complaints of ongoing fever, cough, body aches, and extreme fatigue. Patient also had a macular rash on his arms and legs. Associated symptoms included chills, diaphoresis, shortness of breath, dizziness, generalized weakness, and diarrhea. He had a past medical history of congenital agranulocytosis and esophageal stricture. His family history was significant for an uncle who died of leukemia in his 30s. Initial physical exam and lab values were subjective of septic shock, as the patient was hypotensive, tachycardic, febrile with lactic acidosis. His CBC was notable for severe pancytopenia with hemoglobin of 7.9, platelets of 6, white blood count of 0.2 with monocyte predominance. The patient has a lipase level of 19 with elevated inflammatory markers. Workup including blood culture, fungal cultures, HIV, CMV, all were unrevealing. Despite extensive antibiotic and antifungal coverage, the fever persisted. Bone marrow biopsy was done and revealed acute myeloid leukemia. Genetic testing was then performed, which revealed a mutation in the SBDS gene, consistent with the diagnosis of Shwachman-Diamond syndrome. The rash on his arms and legs was thought to be due to sweet syndrome, which is a very rare inflammatory skin condition, also known as acute febrile neutrophilic dermatosis. Our patient underwent an unrelated donor peripheral blood stem cell transplantation and was started on steroids and granulocyte colony stimulating factor. He has since recovered well and returned to his normal activities. Individuals with these disorders are increased risks for developing myeloplastic syndrome and AML. Once they develop AML, the prognosis becomes poor. This disorder is classically diagnosed in childhood, but can be easily missed as signs and symptoms are variable. There's no treatment for SDS at this time, and the approach is usually multidisciplinary, involving hematologists, gastroenterologists, orthopedists, endocrinologists. Future research into identifying methods of early detection and treatment of these disorders are needed.